Assalamu alaikum, salam sejahtera, and a very good morning to you all. This is the first breakfast at UMHealth for March 2023, and the topic for discussion today is really quite salient as March has been designated as Colorectal Cancer Awareness Month. With me today to discuss colorectal cancer awareness, particularly in Malaysia, is a very diverse panel which reflects how the management of colorectal cancer is increasingly multidisciplinary. So first, I would like to introduce the speakers. With me are Professor Dr. Anushya Vijayananthan, and she is a consultant radiologist at the Department of Biomedical Imaging in the Faculty of Medicine here at University of Malaya. We also have Dr. Nisha Muhammad Shariff, who is a clinical oncologist at the Department of Clinical Oncology, also here at the Faculty of Medicine, University of Malaya. And Associate Professor Dr. Khong Loon is a consultant colorectal surgeon. He's also the head of the colorectal surgical unit at Faculty of Medicine, University of Malaya. And later on, we will be joined by Dr. Chow, who's a family medicine specialist, and she's the head of the Taman Medan Health Clinic. So to kickstart the panel discussion, I'm just going to be presenting a few slides on what the state of play is with regards to colorectal cancer globally, but more specifically here in Malaysia. Okay, so what is the state of play for colorectal cancer, or indeed, what is colorectal cancer? As most people would know, it's the cancer of the large bowel, but where there is some confusion is that the large bowel is a catch-all term for different parts of it. And so you have the colon, which is this area here along the pink tube, but when you get towards the end, you have the rectum. And finally, the stool passes out from the anus, but the anus has actually been separated from the terminology for colorectal cancer. As you can see on the left, the cancer or the tumor grows and will start to invade into the bowel wall, and the greater the depth of the invasion and subsequent spread will determine what stage it is at. So you have the earlier stage, which is stage 0, and it progresses to stage 4. What are the causes? And I'm often asked this in my clinic. Unfortunately, there's no single answer because it's multifactorial. So a large part of it is with regards to your lifestyle, your diet, and even perhaps the drugs you're taking. But that also interacts with the bacteria in your gut and also your genetic predisposition. So it's multifactorial. But what we do know that in many cases, it begins with a benign polyp, but then subsequent changes and mutations results in cancer. It's very common around the world. It's consistently in the top 3 of cancer cases, and also in the top 3 for causes of death from cancer. And if you look at this world map, you can see that it is also different in incidence across the world. So Malaysia is somewhere in the middle, not too high, not too low, but unfortunately it is rising. And it's similar for both males and females by and large, although slightly skewing towards an increased male preponderance. So in Malaysia, you're having about perhaps 3,000 new cases a year. And you can see the pattern here is very similar to the world pattern in that it is now number 2 in terms of cancer incidence in Malaysia, and it increases with age. We also have uniquely very diverse ethnic population, and you can see that it actually differs between the different ethnic groups. Unfortunately, like the rest of the world, we are starting to see a rise in the incidence of young colorectal cancers, defined as being below the age of 50. Nevertheless, the largest cohort of colorectal cancers is still in the over 50 age group. Unfortunately, in Malaysia, patients are presenting late. More than 2/3 of them are presenting at stage 3 or 4, and you can see that with a higher stage, 5-year survival is significantly lower. And it also matters where you are in the country if you happen to develop colorectal cancer, because survival is different according to location in the country. Unfortunately, in addition to its impact on lifespan, it also affects quality of life, and one of our speakers will be going into more detail of this. And this is, despite having a good overall function, there are specific areas of function that are significantly affected. And it also leads, unfortunately, to increased healthcare costs, both to the end user but also to the healthcare system. As we get better at treating colorectal cancer, unfortunately, we also have to start dealing with the long-term survival chronic side effects. And again, one of our speakers will be addressing this in more detail. Okay, so to kickstart our discussion, I'm going to invite Dr. Nisha to talk a little bit more about late diagnosis in colorectal cancer, because as has been mentioned before, more than 2/3 of Malaysian patients present at stage 3 or stage 4, and perhaps you could delve into some of the reasons for that as well. Dr. Nisha.
All right, thank you very much, Prof. April, for a very kind introduction and setting the scene for our breakfast talk today. First of all, welcome to Colorectal Cancer Awareness Month. My name is Nisha. I'll be speaking on the implications of a late diagnosis in colorectal cancer. So the outline of my talk will include local data on the colorectal cancer diagnosis, the economic burden of a delayed diagnosis, as well as the psychological impact. So as demonstrated previously, when we look at the Malaysian National Cancer Registry, what is striking is that you can see that in men and women, patients who are diagnosed with stage 1 and 2 have actually decreased when compared to the previous registry for the years 2007 and 2011. And the numbers of patients who are diagnosed with stage 3 and 4 is actually increasing. So I feel this is quite worrying, and we need to make some important steps in order to curb this. 70% of patients with colorectal cancer are diagnosed at stage 3 and 4, as demonstrated earlier by Prof. April, and less than 30% of patients are diagnosed with stage 1 and 2. And when we compare our data with our neighbors in the Southeast Asia region, you can see that the numbers are pretty similar. In Thailand, hospital registry was published in 2016, and you can see again about 70% of patients were diagnosed with stage 3 and 4. In Vietnam, similarly, almost 70%. But in our more higher income neighbors in Asia, Japan, it shows that about 55% of patients were diagnosed with stage 3 and 4. So you see that with higher income countries with more active screening processes, perhaps we can actually detect these patients earlier and reduce the number of patients diagnosed with advanced stage. So we look at how are we doing in UMMC. So I pulled up the census from our oncology clinic for 10 years, from the years of 2009 to 2018. And you can see that, you keep in mind that the numbers that you're seeing here, really patients that were diagnosed, were referred to the oncology clinic. We do not see stage 1 patients. We see patients with stage 2, 3, and 4 that may need adjuvant treatment. And the take-home message here is that, similarly to what I demonstrated previously, about 70% of patients were diagnosed with stage 3 and 4, and about less than 20% of patients were diagnosed with stage 2. And these numbers were the same when we look over the whole of the 10 years. In fact, in some years, even higher numbers of patients were diagnosed with stage 4 when compared with stage 3. And so what is the problem when we are diagnosed with a later stage of colorectal cancer? The biggest issue here is that the prognosis of these patients is very poor. When you look at the survival curves, when the patients are staged according to the AJCC TNM 7th edition, you can see in patients who had stage 1 and 2, the 5-year survival rates were more than 50%. When you had stage 3 disease, the survival drops to as low as 30%. And if you had stage 4 disease, your 5-year survival is a dismal 10%. Similarly, in Malaysia, this report also shows that in patients with stage 3, the survival is about 30 to 40%. And in patients with stage 4, it hovers around 10%. And it's the same as was reported globally. So the implications of late diagnosis, I've talked what is the most important of which is the reduced survival and poor prognosis. But there are other things that we have to look at as well when we think about how it impacts the patient, the community, as well as the nation as a whole. So the most obvious thing that you can see would be the direct medical costs as a result of late diagnosis. This includes the cost of treatment, investigations, the cost of palliative care, and support in the community as well. There are also non-medical costs, such as the cost of transportation and food that these patients may need to spend on when they come to the hospital or an inpatient. The indirect costs of a late diagnosis are more difficult to quantify. Productivity losses as a result of disability, morbidity, as well as early mortality happens not in patients, as well as it affects the caregivers as well. And the time that the patient is spending while in your waiting room also needs to be accounted for. And the psychological impact is quite significant as well in patients as well as the carers. So looking at these two reports, you can see it's obvious that the economic burden that patients experience when they're diagnosed with a later stage, in stage 3 and 4, is far higher than patients who are diagnosed with stage 1 and 2. And these estimates are very conservative. These estimates do not include more expensive targeted therapies, the detection of recurrences, and as well for the use of palliative care in patients who survive more than 1 year. And when we look a bit more locally and with more up-to-date kind of numbers, let's see how much our patients are spending when they receive treatment in UMMC. So this is just an estimate. When you have stage 1 and 2 disease and you may not need adjuvant treatment, you just undergo surgery, the cost of treatment may be quite manageable. But once you are diagnosed with a later stage, you can see in stage 3 and 4, the numbers increase. So in patients who typically are diagnosed with stage 4, you have 2 lines of chemotherapy, you add on targeted therapy, the cost that these patients spend in total almost double the cost spent when they are diagnosed with stage 3. And this does not include, as I've mentioned earlier, waiting time, the transportation costs, medication costs for symptomatic care, as well as other oral medications which they may be taking home, the psychological stress that these patients experience, loss of income, as well as carer burden. In Malaysia, more than 2/3 of colorectal cancer patients find it difficult to cope with the expenses of colorectal cancer treatment. And this financial burden is, we are lucky in Malaysia, it's heavily subsidized by public healthcare services. And you can see that this indirectly impacts on the country's economy. These patients also need to have out-of-pocket expenditure, out-of-pocket spending for the treatment. Some of them have private insurance premiums. They may need to take loans from financial institutions. We pay from our taxes as well. And we are able to withdraw from the Employee Provident Fund and Social Security Organization contributions. So this phenomena which we are experiencing in Malaysia is not unique. It's experienced globally as well. And looking at this table, you can see that the annual cost of patients that they spend on colorectal cancer in the last year of life doubles the amount that they spend on the initial first year after diagnosis. And this expenditure includes medical service as well as oral prescription drugs. And this is in US dollars. So loss of productivity, as I've mentioned previously, is very hard to quantify. It can be defined as a monetary value of output that would have been produced if this patient does not have the illness, disability, or premature mortality. In 2010, productivity losses from colorectal cancer morbidity and mortality is estimated to be as high as $20 billion. And as mentioned, the numbers of patients with a younger diagnosis of colorectal cancer is increasing. And in this younger population, they contribute a larger labor force participation, and it can even be higher than what was estimated. So simultaneous interventions, and I'm talking about risk factor reduction, screening measures, as well as chemotherapy use, is able to save on total productivity losses and was estimated to be $4 billion for the year 2020. Now, what was interesting was that screening actually avoids the greatest number of deaths from colorectal cancer. So psychological impact is something that often goes unnoticed, undiscussed. Patients with more advanced stage were found to be more anxious, depressed, and they perceived their social support as lower. They also had a worse quality of life. And in advanced colorectal cancer patients who are undergoing chemotherapy, the survival of these patients tend to be better if they had a better quality of life score. So I've talked very briefly about screening just now and how it saves the most amount of deaths with regards to productivity losses. Does screening really detect colorectal cancers earlier? So you can see in this one of the very large earliest randomized controlled trials, you can see that there were two groups. One was a screening group, one was a control group. It was found that screening detected more Dukes A or early stage tumors. They detected, the screening group detected lower numbers of advanced tumors in Dukes stage C and D. And disease-specific survival in individuals with colorectal cancer were higher in the screening group when compared to the control group. And there was also a 15% reduction in colorectal cancer mortality in the screening group. In conclusion, majority of colorectal cancers are diagnosed with an advanced stage. The numbers hover around 70%. Advanced stage colorectal cancer is associated with a poorer prognosis, and the diagnosis of colorectal cancer also impacts on the patient's finances, productivity, psychology, as well as quality of life. Thank you.
Okay, thank you very much, Dr. Nisha, for that succinct presentation on how we're doing in terms of stage at presentation. You mentioned, and I also mentioned a little bit about young colorectal cancers, and they generally don't come within the screening population. Do you think that affects their stage at presentation?
Yeah, so often we find that these patients with early colorectal cancer tend to be more aggressive, and they come with more advanced stage. They probably would have missed the time where they could have been picked up at a kind of pre kind of clinical stage before they exhibited any symptoms. But also these patients are very active in their life. They're still active in the workforce. You know, when they have a symptom, they probably think that it's due to an infection really rather than due to malignancy, because it's almost unheard of, right, for patients to have cancer at a young age according to the public members. So they may put off their symptoms longer, and they may only seek treatment when it's really more advanced.
So clearly we have a lot of work to do in terms of raising awareness, but it does, for a healthcare system, it does create this conflict, doesn't it? Because on the one hand, you have the cost of running a screening program, and on the other hand, you have the expense of treating them at late stage. So how do you balance the two? So clearly, from the discussion, we need to do something to detect patients at earlier stages, and that's where screening comes in. But certainly for those of us in a hospital setting, we find that very difficult to implement, and I'm interested to hear what it's like in the GP setting. So to talk to us about engaging patients in the community with regards to colorectal cancer control is Dr. Chow Suet. Dr. Chow, please, the floor is yours.
Yeah, very good morning to everyone, those who are here physically and those who are virtually. Thank you very much for taking your time, your precious 8 to 9 o'clock time to listen to this colorectal cancer awareness. So I'm congrats to you all for taking some time to listen. So I'm Dr. Chow, the FMS and the head of clinic in Taman Medan Health Clinic, KK Taman Medan, under Ministry of Health. So I'll be talking a bit about how we engage to the community on colorectal cancer screening. So, So as what my two previous speakers already has mentioned, that colorectal cancer is actually one of the top 3 colorectal one of the top 3 cancers in Malaysia. And as you can see that the previous speaker, Dr. Nisha, has mentioned that if we do not detect early, there's a lot of costs has been incurred, not only the treatment, but also the labor costs and the waiting time, the transportation. So there's a lot of things that will be incurred if one is detected late. So how do we do about getting patients to come for screening? Okay. So in the primary care, in the Ministry of Health, there are a few different types of modalities of colorectal screening that is done in KKM. So the main one that we normally do is actually the IFOBT, the stool test, or if they are at the moderate to high risk factor, they are on the moderate to high risk, we will actually refer for colonoscopy. Or if they are symptomatic, then we will refer them for colonoscopy. So those are the two things that normally when the patients come to our clinic, we will do that. We will offer that screening for them. Okay. So of course, it depends on the risk factors as mentioned. If you have the high risk or the moderate risk, then your age more than 50, then we will proceed with colonoscopy. But if you do not have, you are in the average risk, then we will probably counsel you for IFOBT, which is just a simple stool sample, just to give a simple stool sample. So as per guidelines in Malaysia, average risk 50 to 75 years old, we do yearly screening with IFBT, and if it's positive, then we will proceed with referral to the tertiary centers for colonoscopy. And if they are at the moderate to high risk, we refer for colonoscopy. And bear in mind that there is no role of cancer marker screening, such as CAA, as a colorectal cancer screening. So I hope this is clear for everyone. Okay. So actually, colorectal cancer screening in Malaysia is not a new thing. It has been ongoing since, I think, more than 5 years. Since 2014 already, we have already started it. Okay. It has gone, initially it was a selected clinic only will be doing that. Subsequently, it expanded and become a full program in Ministry of Health. So initially, they suggested the different types of suggestion of colorectal cancer screening is in a population is mainly house-to-house approach, awareness campaign, and for Ministry of Health in the clinic kesihatan is opportunistic screening at healthcare facilities, in which if the patient comes for NCD, non-communicable diseases, or maybe they come with outpatient complaints, after we address the acute complaint or we address their non-communicable disease follow-up, for example, diabetes, hypertension, we will offer them, if they say they're at risk, or if they're at the age group 50 to 75 and they have at the average risk group, then we'll offer them, okay, Encik, sebenarnya ada satu saringan sangat-sangat simple nak buat bagi the sample berak najis untuk buat saringan cancer. So our medical officers and even the FMS will actually offer to the patients for this. And we'll tell them it's very, very simple because all they need to do is just give us stool sample, come back to the clinic to give the stool sample, and we will do the testing and we will call them back if the result is abnormal. However, throughout the many years, despite saying that this is very simple, and even the acceptance rate in this study has shown that actually it's quite high. Patients are accepting it, but yet the implementation and the coverage of screening still remain low. Even in 2018, it's less than 1%. Surprisingly, it's very, very low. And of course, if you do house-to-house approach, it's definitely the highest acceptance rate. But of course, it's very, very labor intensive, and you have to involve a lot of people just to tell the patient, okay, I'm coming to your house, I'm going to collect it, reminding them. So that it's not feasible in a public setting, in a KK setting. Okay, so from that study by Aruna Chandran, by Aruna Chandran, what we found is that from the healthcare perspective, because we were wondering why the acceptance rate is so high, but yet patients are still not giving the stool sample. What is the issue? So that study, unfortunately, because they only interviewed the healthcare providers, so they found that mainly when we ask the healthcare providers, they will say that clients refuse because they say, najis, sangat jijik, it's disgusting, or it's privacy. Kenapa saya nak bagi sampel najis? It's like very sensitive thing to give to other people to see your najis. Okay? So that is one of the barriers according to the healthcare providers. And at the same time, what will happen is that if they turn positive, they don't want to go to the hospital for colonoscopy. Or even we given the appointment, initially they say, yes, we are going. But the next day when they come back, belum buat lagi, belum pergi lagi. And of course, there is sometimes even the doctors are not aware that we should be encouraging patients to do colorectal cancer screening. Okay? And even if they go back, you will go to the hospitals, what happened is that there's no two-way communication. There's no refer back to the primary care was not well established. Which later I'll explain about the project we're doing with Verbom, collaborate with also, how we try to counter these barriers. And of course, if we do the screening, then definitely need to have availability and accessibility to colonoscopy, which is, if let's say there's many referrals, can the hospital cope with the referral? So we talk about, just now I will talk about the healthcare providers' views. So is there any views from the population? Why actually they themselves don't want, even though we encourage them, even though it's very clear and it's been gone on for this colorectal cancer screening since 2014. So what they did by Cogila et al., which is just a recent study, they found that when they did a qualitative study among the barriers of why they don't want to do the colorectal cancer screening, is mainly, the themes are mainly emotional concerns, logistic concerns, and absence of invitation from the healthcare provider. So for the patient, same thing like what we mentioned, feeling of embarrassment, discuss regarding stool sample and collection, and logistic concern. Once we refer them, it takes some time. Maybe the referral is not within 1 to 2 weeks time. It's like maybe TCA in the busy government health clinics, government hospitals, it might be maybe 1 to 2 months. So that, because of the waiting time, patient said, okay lah, tak mau pergi. It's too late already, it's too long to wait. Or maybe they have difficulty coming back to give the stool sample, because what we will do in the clinic setting, we will give the patient to go home and get the stool sample, and then they have to come back. And bear in mind, most of the patients who are coming in, because they're elderly, those that we are screening are actually the 50 to 75 years old. So what happens is that they depend on the children to return the stool sample. So what happens is that the bottle is given but it's not returned. And of course, in a busy clinic, there's so many programs running. So sometimes when the patient has multiple comorbids, we are addressing the comorbids during the follow-up, the doctor tend to forget about offering this screening test. So like what in my clinic myself, what we can see is when I ask my own staff, my doctors and my nurses, because my nurses are also encouraging patients to do the screening, what they do, they will encourage and then they will put in the form and it will go into doctor's room. So it's like the nurse has their advice, the doctor advice. So when more people advise, we expect patients say, ya betul, memang banyak orang cakap memang penting untuk buat colorectal cancer screening. But what happened is that they don't want. They say jijik, disgusting, malu. Kenapa nak buat? Saya kan okay, saya tak ada gejala apa-apa, saya tak berak keluar darah. So they don't think that it's important. Okay, and of course the difficulty getting them. Yes, sometimes we somehow push the stool sample specimen bottle for them, but they end up not returning the bottle. Okay, so in that study, Cogila et al., they suggested for the healthcare provider to call them back to return the specimen bottle. Whether is it feasible, maybe we will discuss later. And of course, maybe if you give incentive, okay, maybe free transport, then they might come forward to screening. Or maybe if you do a community outreach, like Empower, when I was working in KK Jinjang, what they did is that if they come for the screening, we will give them a bottle of a packet of rice. Okay, so they get something, and of course, they get some sample. Okay, there's a dedicated health screening for participants who receive containers for samples, and at the same time, committee leaders are also involved, because most of the time, when the committee leaders are involved, people tend to listen, okay, because they are part of the people, whereas we are healthcare providers. So these are what been done so far. Even in KKM, we're also using COSPAN, Committee Perkasa Negara. But what happened is that it is, every time when they change the team, we have to train again. So it's not so feasible. And of course, other NGOs like Empower, Rotary Club, Lions Club, they're also involved in that. Okay? So when we look at Empower, they have actually done a study by Christina et al. They actually done quite a labor-intensive kind of program whereby they actually work with committee leaders. They spend time teaching the selected subjects to give the feed kit bottle, and they provide a collection center to drop off the feed kit. And at the same time, after that, they will break the news at the privacy of their homes. And everything has been arranged. Transportation for colonoscopy, and also emotional moral support given throughout their medical journey. So it's quite labor intensive, but it makes the patient feel that, yes, we are with you throughout the whole journey of colorectal screening to diagnosis. So like what I say, is it feasible and cost effective in most primary care settings? Okay. So hence, when we did in a pilot project in Klinik Kesihatan Taman Medan, Rebong, it's actually, Rebong stands for Reducing Barriers in Cancer Early Diagnosis in Urban B40 Group. It's mainly aimed to provide a full package of support from the start of screening to confirmation diagnosis to treatment and follow-up to urban B40. And this cancer is not only colorectal cancer, but also screening for cervical cancer, breast cancer, and lung cancer. Okay. So it started in January 2022. My clinic was chosen. It started with, first we need to train the healthcare providers, okay? Get them aware about what is colorectal cancer and other cancers. Okay, so you can see this module got many packages. Okay? And then of course we had to advertise to the community, because what's the point of training our healthcare providers, but the people are not coming to the clinic for the screening. And then we need to collaborate with the tertiary centers. So we collaborated with Hospital Shamla mainly and PPUM on the referral. So it makes it speeds up the process. So the moment positive, a person, licensed officer in my clinic will actually link and message the person in the hospital to get an early appointment. And so Hospital Shalom even allow walk-in for our cases. And of course, continuous CME for our MOs. At the same time, another interesting thing is that we help the GPs if they are also doing screening, but because they have to pay if they use their own referral letter, we gave a covering letter to waive off the fees. So we are partnership with the private GPs. So this is what we did in community. We teach the patients how to register and how to come to our clinic, how to make appointment. So my doctor is actually teaching, my nurses are teaching that. So we try to do an outreach program to encourage patients to come on their own to the clinic just for colorectal screening. Okay, so this is all the flow chart that we've been doing. And then a covering letter for the GPs too. Okay, and then a bit of flyers for the patients and the GPs too. And actually last year, what we did was that when we did the screening, we found that quite high, about 19.6% IFBT positive, and because we involve the community, whereby the community leaders are the ones reminding them to go for hospital, the uptake in the end for them to go to hospital is quite high, 92.8%. Out of 28 were positive, 26 over 28 actually went to the hospital. Only 2 of them didn't refuse referral. So this is what we did. We invited the community leaders to actually show what is happening in our clinic, so that easier for the community leaders to tell the patients that it is not that difficult. They don't really need to wait very long. How is it done in the clinic? We show the stool sample and everything. And we also involve another clinic, which is going to be the pilot study for, I think, Verbum 2.0. Okay. So we're looking forward for more NGOs to join with us. Okay. Thank you.
Thank you very much, Dr. Chow. It's clearly a big challenge to try and get our population to take on screening for colorectal cancer, and indeed screening for anything, any cancer. And I think it's important to emphasize here that when we're talking about screening, it is really asymptomatic patients, and that reflects their concerns. Why should I get screened if I'm perfectly okay? So those are the challenges in the community, but we also face challenges in the hospital setting in terms of implementation of screening. So to talk us through some of those challenges is Prof. Khong. The floor is yours.
Thank you very much, Prof. April. And thank you very much to everyone who's joining us today this morning. I'm really encouraged to see that we have close to 100 participants, and we have some in physically here as well. And clearly all of us have an interest in trying to control this non-communicable disease. I think one of the take-home messages is that colorectal cancer is a highly curable condition. And you can see from the presentation so far that it's highly dependent upon stage. So the earlier the patient presents to us, the higher the chance that we are to achieve cure and get the best quality outcome for them as well. So, which is why that if we can actually retrieve and excise these lesions endoscopically when they're in the pre-malignant phase, it is a highly desirable position to be in. So clearly what we're trying to outline here today is about screening and how its role is in trying to detect a disease early. So Dr. Chow has given us a really great insight into how that is implemented in the community, trying to engage with patients who are asymptomatic about how they have intrinsic risk to develop colorectal cancer. And what I want to share with you is what happens to those patients after they've tested for FOB positive, and how many of them actually do progress on to having further investigations. So just very briefly, Dr. Chow already mentioned that in bowel cancer screening here in Malaysia, it is opportunistic. meaning that this is not a population-based screening as what you may hear about in the Western world or in the first world developed countries. So meaning that we normally engage with these patients because they have specific risks. And the most important thing is to appreciate is that all of us actually have a risk of developing bowel cancer. So on average, we all have about a risk of 5 to 7%. So if you appreciate that, meaning that you and I can potentially develop a condition, then you will actually want to detect it early by being a bit more open to earlier investigations. So the target population that we are aiming for in opportunistic screening are those who are 50 to 75 years of age, and they have to be asymptomatic. If patients are symptomatic, they have to go down the route of being managed accordingly. So the first modality is basically stool-based tests, and this normally comes in the form of either an immunochemical test, as how you would have been very accustomed to with the COVID and the RTK tests, and the other one is just the quantitative test. No matter which form it takes, if this is positive, then the patients are highly advised to progress on to having a colonoscopy. And the whole premise of this is to hopefully detect adenomas, meaning small polyps when they're still very manageable endoscopically, or the hopefully diagnosis of cancer at an early stage. So it sounds very simple. It sounds very easy to implement, but we already have data showing that although patients even go ahead and have their fecal test, only a small portion of them will actually go on to actually having a colonoscopy. So this is a local study which shows that only a quarter, 1 in 4 patients who are eligible for colonoscopy because they've tested positive for FOB actually go on to having a colonoscopy. And this is really rather worrying. These patients actually know that there's something intrinsically wrong with their colon, but yet they prefer not to know that something is wrong. This is a national study which is done by the Ministry of Health, and as Dr. Chow mentioned, the opportunistic bowel screening has been going on for a while, since 2014. So what they did in this study was that they looked on year on what the CRC screening uptake was like, what the FOBT positivity rates were like, and what the colonoscopy uptake rates were like. And unfortunately, the results are pretty harrowing here. So the denominator here for the CRC screening uptake are basically the population who are aged between 50 and 75, so the ones who are eligible for bowel screening. And the uptake is only 2.3%. And bear in mind that these are specific primary healthcare institutions that have a focus and role in trying to promote screening. Out of those who took up FOB, about 10% of them tested positive for FOBT. And just to give you a rough reference, in the West, in the UK with the bowel cancer screening program, only about 2% of patients actually test positive for FOB. And look at this. Yet again, really poor colonoscopy uptake. Only about half of the patients who are eligible for progressing onto colonoscopy actually took it up. So this is yet again really disappointing. So clearly we need to actually work with our patients. We've come to realize that no matter how much you scream and shout and give them incentives, etc., we really need to identify what is it that's actually underlying patients' feelings, thoughts, emotions about getting colonoscopy. So this is an amazing piece of project that was done by Stephen C., one of our surgical MOs. And what he did was he basically looked and saw what was it that was actually preventing our local population from progressing on to having their colonoscopy. And the most important thing that we found is that the patients didn't feel that they needed to have any investigations because they're symptomatic, just as what Dr. Chow said. You and I, we are all humans, and at the end of the day, if we have a bit of toothache, most of the time we just say, well, it's okay, we'll sort it out later, and it goes away. But it may be different when you have a malignancy that's brewing within you. So I think it's very important that we need to highlight to the population that although they may be asymptomatic, but as I said before, we all have intrinsic risk of having colon cancer. It's just that we don't know it. So the second most important factor is that patients are not being advised. So I have to say that I'm very guilty of it, being in a busy clinic like Dr. Chow. I may be seeing a patient who presents with a non-malignant condition, like diabetic disease or whatever it is. But because they fall in the age group and I don't have time to counsel them about bioscreening, patients leave without understanding about why it's important to do bioscreening. So amongst all of us, we see patients that fulfill this criteria, yet we have to ask, do we actually tell our patients, do we actually encourage bioscreening? So the next few things after that are big emotions and about people logistically finding it difficult to perform bioscreening. And we find that a lot of these problems that have been highlighted can quite easily be solved through navigation. So some of you may be familiar with navigation. Navigation is not something new. It's actually been coined in the 1980s or so, and particularly to treat non-communicable diseases, particularly hypertension, diabetes in the past, where we wanted to try to improve compliance of patients towards treatment. So what Stephen did, my MO, was that he actually created a custom Malaysian local customized tailored navigation program. And what he did was that he used the data that he had about why there were barriers to patients taking out screening, and he basically tried to improve their understanding of bowel cancer, what colonoscopy is actually about, that it's not the underworld having an internal examination, and what happens when they come to our endoscopy unit, and more importantly, about how bowel preparation should be taken. Okay, I'm sure that some of you may have bowel preparation before. It's not a pleasant experience, but if you are actually if you're primed about what it is about, I'm sure you'll find that experience not too bad. And so what do the results show? Navigation really works. It is effective and improves attendance rates. Yes, it is intensive. We need to put effort into it. But as you can see from the second row, the number of patients who attended screening colonoscopy who had navigation was 2.5 times higher than those who didn't have standard treatment. So why may this be? Well, perhaps it's got to do with emotions, maybe it's got to do with anxiety, maybe it's got to do with how they perceive their health. And sure enough, this is what we found. If we use the hospital anxiety and depression scores and we ask the patients before and after the scope, those who had navigation, you can see in this navigation arm that the pre-colonoscopy and the post-colonoscopy depression scores were significantly lower. And compare that to the control arm, which had no, obviously, navigation. And interestingly enough, if you compare the pre-colonoscopy scores for the standard control arm and the navigation control arm at pre-colonoscopy, they are also lower, meaning that the patients who actually knew that they were going to navigation even before colonoscopy seem to have less depression. And this similar data is shown for anxiety as well. So much better in the intervention arm compared to the control arm. And if we look at the patient wellness score itself, particularly looking at GHQ-12, yet again we see the similar difference between the control and intervention arm, where the intervention arm had much better well-being scores after colonoscopy as compared to pre, and same again in the control intervention arm, we see the difference there as well. So the bottom line at the end of the day is that we know that screening works. We can encourage patients to go ahead to have screening. The implementation is the barrier, and it's about how you and I can work together to try to overcome these barriers. Thank you very much.
Thank you very much, Prof. Khong. It's human, isn't it, to always let day-to-day life interfere with maybe health preventative measures. And colonoscopy is not the most pleasant thing to anticipate. So perhaps there are other ways, and perhaps Prof. Anushya can tell us if there are any less invasive ways of screening.
Thank you very much, Prof. April, and a very good morning to everyone. I don't know whether save the best for last actually applies here, but I'm just going to go with it. All right, so what is CT colonography? I think we've got a vast group of people online and also here, from non-medical to medical students and those of us who work in the medical line. So CT, everyone knows what CT is, computed tomography, colonoscopy, is actually, it's somewhat like a virtual colonoscopy, okay? So what it actually is an imaging test. And you know now with radiology, we've moved in leaps and bounds because it is image-based, technology-based, and technology has just flown in the past few decades. And similarly, screening tests for all parts of the body has actually become something that's being dealt with very much over the past 1 to 2 decades. So it's imaging. It's basically you lie in a machine, and because now we have CT scans that can do thin slices, you can actually reconstruct these images in 2D, 3D, whatever it may be. We'll show you a few images later. And it requires bowel prep as well, maybe about 2 to 3 days before, similar to a conventional colonoscopy. And you will have to take a low residue diet and, of course, flush out your bowels with medication and so on and so forth, just to make sure that everything is clean. And then it's done basically like an imaging. So the indications are basically for patients who have an incomplete colonoscopy. Sometimes it's difficult to navigate through the bends of the colon. And for colonoscopy, you'll need sedation. Sometimes there are patients who have got comorbidities and they are, contraindicated for colonoscopy, or simply because somebody does not want to have a colonoscopy, and therefore you can have an alternative to a colonoscopy, right? The other thing is that we have to know that when you do a CT, you can look at the entire body. So one of the plus points is that you can actually find other extra colonic findings, maybe, incidentally when you do a CT. And of course, there's no sedation required. All our patients are wide awake. So what do you expect when you do a colonoscopy? Of course, you clear out your bowels with laxatives, and that would be about 2 to 3 days before with a low residue diet. Sometimes in certain centers, they'll give you a little bit of oral contrast to drink for fecal tagging. We don't usually do that here because if you clean your bowel out very well, we don't really need that. And on the day, you can see here, on the day of the test, we still do have to put in a small tube, but that's just at the lower rectum to inflate some air in. And then we do a CT scan. So the scans are done in both supine and prone. The reason why it's done in prone position is because the rectosigmoid gets distended in the prone position, and you can see the area very well. And then we turn the patient supine and we do a normal CT scan like how you would do, of course, with the air inside, but you do it with IV contrast as well. Yeah. So that's basically how it's done, right? And you can see over here, you just lie in a scanner, so you're totally wide awake. You'll have an IV line, and of course, you'll have a little tube that goes into the lower rectum, like I said, and you pump in air. So the concept is that when you put air into the bowel, if you've got a marble in a balloon, let's just say, right, but the balloon is deflated, it's a little bit difficult to look for the marble, but if you inflate the balloon, the marble's very, very, very easily seen. So the same concept, you need to distend whatever it is that you're looking at for you to pick up stuff that is small in the wall. Yeah, so that's basically it. So if you look at this is basically how a CT colonoscopy will look like, right? And you can see that these are the areas that are a little bit difficult to navigate, and they're bendy. And you can even see sort of like a filling defect here, which shows up very clearly as a polyp. And we have reconstructed images, and that's how you can get your reconstructed images in 3D. This is basically what the original CT image looks like, and when you reconstruct it, you can see the polyp, and that's it on a scope. So it's very, very similar to what you would actually see on a colonoscope. Yeah. So of course, there are lots of papers out there comparing, because this is a new modality, comparing CTC with your occult blood test, and looking at the uptake. I mean, if you tell, if you tell a patient to go for a CT scan, they are also a little bit apprehensive. And the one or two things that they ask for, first thing they'll say is, what is the risk of radiation, right? So that's the question every time. And that's one. And the second one, of course, is the risk of a ruptured bowel, because you tell them you're going to pump air inside. Of course, we don't pump it to the point that the bowel ruptures, and it's very, very rare that actually occurs, hardly ever. But these are concerns that actually needs to be addressed. Yeah. So the most important thing is whether or not it's comparable to colonoscopy. So there's lots of papers out there, of course, analysis, especially after CTC or CT colonoscopy or colonography became something that was being, sort of explored as a screening tool, right? So lots of analysis there. Of course, direct visualization is definitely better. But like I said, this is an option that can be explored in certain cases, right? So if you look at this that I've put up on the screen here, you can see that according to size, it also makes a difference, the size of the polyp. And if the polyps are larger, you can see that the pickup rate is a lot better. So there are papers that look at usually 6 millimeters to 10 millimeters, which is the diameter of the polyp. 10 millimeters is very well, established that you can pick them up very well, and more than 6 mm as well. Usually the gray area is somewhere between 6 and 10. And you can see here, where I'm showing you with my cursor, that when you have lesions that are larger than 10, it's very, very comparable. But of course, the sensitivity for the polyps lower or smaller than a particular, like, in 5 and 7 mm, you can see that in CT colonography it's less. And of course, the flat lesions, the pickup for flat lesions are not really that good, yeah, because you can miss them definitely on CT colonoscopy rather than direct visualization. So there are lots of there are two minds in this, actually. That's why it's always up for discussion. There are benefits. There are benefits for CT. Like I said, extracolonic findings. You don't have sedation. There's of course, you've got to explore the cost in having a CT, and there are also drawbacks. So I think it's very exciting as a tool, especially in those patients, like I said, who have incomplete colonoscopy, who don't really want at all to go for a colonoscopy, and also to explore the extracolonic findings. So I think this is a very exciting screening tool. Thank you.
Thank you very much, Prof. Anushya. I'm interested to hear from the surgeon who obviously performs colonoscopies. What's your thoughts on CT colonography? Do you think it's going to put you out of business?
Thanks, Prof. We know for a fact that we are still okay when the radiologist still can't remove the polyp or biopsy any lesions. So I think we are still safe from that perspective. There's certainly a role for CT colonography, as Prof. Nisha mentioned. So I think in our clinical practice, we primarily use it for patients where endoscopically it might not be possible to complete their colonoscopy. So for all of us, we may have some aberrant anatomical variants, and so that might make it difficult for us to complete a colonoscopy. And therefore, this is where a CT pneumocolon will come in very handy. So that's certainly where I see the role of CT. Currently, it's still quite costly.
Yeah.
So certainly from a cost-effective analysis, there isn't a role for using CTC as the second modality compared to colonoscopy.
Yeah, I know cost comes up a lot, and that is unfortunately something that is a very important consideration. And if you're looking at doing population screening where you try and screen everybody who's eligible, then you have the stool tests, which are less than 10 ringgit each, and then you have your CT colonography, which is probably
500 to 600, yeah.
Yeah. And multiply that by the number of population
Yes.
that you need to screen, which is probably in the region of about 3 million or so. Yeah, so that's where in a healthcare system, it actually impacts the choice of the screening tool. But there are differences when it's in private care, where it's either out-of-pocket payments or it's insurance. And perhaps I can ask Prof. Khong again. Do you think that the data that we presented, do you think it differs markedly in the private setting?
I think so. I think market forces are different in Malaysia, particularly where there is also a strong presence of health insurance. My take is that if one is eligible for bowel screening, I think one should take the opportunity. And if the cost is an issue, then we should definitely try to offer this dual modality. But where if screening is offered by the insurance companies, which I understand currently isn't, this is where I have beef with, because to me, the current insurance policies are not encouraging uptake of screening, and it's very much focused upon treating illness instead. So I'm opening up the floor to ask what people think about that.
Yeah, no, that's absolutely true, because a lot of insurance companies will not reimburse for screening of colorectal cancer.
I think in the private setting, unfortunately, the misconception is that they're using the cancer marker screenings as a cancer screening, which is actually wrong, because it's not a screening tool. Actually, it's not even in the guidelines. So actually, it's just a simple IFOBT will be sufficient if you're in the average risk group, and most of them are actually at the average risk group. Those with moderate to high risk, most of the time they already seen that their family members have it. They are definitely, if you tell them that they need to go for colonoscopy, I think definitely they will go for it, because they themselves see it. The challenge for us in primary care is the average risk group who don't feel that it's necessary. I don't have any symptoms. So maybe, I don't know whether if we can convince the insurance company to include IFOBT as part of the package, it might change the landscape, the understanding. Then maybe there will be more uptake because it's part of the full medical checkup package.
So is colonoscopy not part of it after you're 50 to have a colonoscopy now in Malaysia?
So basically, you have primary screening and you have secondary screening. And primary screening, if you're trying to do population-based screening, is usually some form of stool-based test. You have the FIT test or the IFOBT, but you also have some stool DNA tests and so on. But once you have a positive primary screening test, then you still have to go for the secondary screening, which is the colonoscopy. So all roads lead to colonoscopy, unfortunately. So even if you do a CT colonography, you find something, you still have to go for a colonoscopy. But it's a question of rationalizing the availability of your healthcare resources and optimizing its use, because not everybody will need to proceed to a colonoscopy. So I'm going to, just in the last 2 minutes or so, go to the questions in the chat box and in the Q&A. So the first one is from Prof. YK Chan. From the patient's point of view, how does one get at the stool while sitting on the toilet bowl or squatting over one? It is the last mile issue that is quite a barrier. So, yeah, Dr. Chow?
Yeah, I'll answer this. Basically, what in my clinic, my lab will actually explain to them that they will have to put a lot of toilet paper at the toilet bowl, or maybe the squatting one, and from there they just scoop a bit. Actually, those who can understand and those who think it is important, it is not actually it's not a barrier, honestly. To me, I think we doctors, because of the time constraint, we have difficulty explaining. And at that time when they come for follow-up with the diabetes uncontrolled, hypertension uncontrolled, it's too many things has been dishing. And then suddenly we say, oh, by the way, we want to do colorectal screening. So that's why for us, we, in Tower Maiden, before we had to move to MySejahtera appointment, we have a QMed appointment. We have a special appointment slot just for cancer screening. So they make an appointment to come for cancer screening, which we encourage the committee leaders to tell them. That's why we taught them how to do the appointment through the phone. But I mean, maybe later Ministry of Health might want to put it in. I think that would be good because it's like just coming just for cancer screening. Yeah, it's like coming for medical checkup. So it should be part of the package. So maybe that might help. But in terms of the barrier for putting getting the stool, how to scope the stool, I think if the MLT is able to explain, the doctor is able to explain, there's no issue actually.
Yeah, Prof. Chan, actually, usually the kids also come with a little flyer that actually explains in a cartoon form exactly what you're supposed to do. It also, apart from putting the tissue, you're also supposed to sit on the toilet seat backwards. Okay, so that the stool actually doesn't fall into the water, it falls onto the dry part, onto the tissue that you have placed there. So it's actually quite straightforward. The next question is about fear of knowing the unknown. I think we've answered that in the presentations. Yes, a lot of it is not knowing what the reality is. And so I think, again, counseling, probably you need to employ somebody who just does specifically counseling regarding screening instead of expecting the busy clinicians to do it. Next was, will IFOBT result be affected by iron tablets or hemorrhoids? With iron, if you're using the FIT test, it shouldn't be affected. The old guaiac test, yes, it might be. But not anymore. Hemorrhoids, if they're bleeding, yes, that may be a reason for a positive test. Okay, from Prof. Chan again. What is the correlation between stool positive and colonoscopy positive results? Could there be a false positive stool test? What is the size of this category? Prof. Khong, do you want to take this one?
Yeah, so we're looking at the sensitivity and specificity of IFOBT. So we're looking at somewhere in the region about sensitivity of around about 70 to 80% and specificity around about that as well. We know for a fact that the IFOBT has its fallbacks because it may not detect the early adenomas. But if it comes back positive, then we certainly would recommend patients to undergo colonoscopy. So the IFOBT isn't perfect. We can increase that sensitivity specificity by adding more stool-based tests, and this can be in the form of looking at presence of enzymes or even DNA, which may have the changes that is more consistent with cancers. But yet again, fecal DNA testing is very expensive, so which is why it's not currently in routine use.
All right, and finally we have a question from Prof. Adina regarding patient navigation and whether it can be made available to people with low health literacy, because obviously you have to be able to read the material and so on. Prof. Khong?
Yeah, Prof. Adina, thank you very much for that question. So what Stephen did was that he actually created not just written material, but it was actually on a video format as well. So this was actually targeting the low income, potentially who may be illiterate. And it also had content in all three languages. So hopefully that would improve penetration. I think that's probably why it worked so well. And he also made an app so that is available to be seen using the QR code that you saw.
Thanks very much, Prof. Khong. So we're running out of time, but I did want to leave the last word to Dr. Nisha. You tend to be involved in the care of cancer patients, once the diagnosis has already been made. So can you tell us from the perspective of an oncologist why you would want screening to be successful for colorectal cancer?
Thank you for the question. At risk of, like Prof. Khong said, putting me out of a job, I It's really difficult. I mean, we get lots of, you can imagine our colorectal cancer MDT is really busy. We have, every week 10, 15 patients that we are discussing, and this is one of the main workload in our oncology clinic. But workload aside, I think it's really difficult seeing these patients, going through their diagnosis of metastatic colorectal cancer. They really struggle financially, emotionally. There's a lot of burden on the family as well. And I think it's quite disheartening to see this, because their prognosis is poor. You try to, make them power through whatever months or years they have left. And I think it's something which the public who is asymptomatic don't see. And as clinicians, perhaps we can try to advocate for the public who have not screened, and really put an impact on how important screening is to avoid them being diagnosed with metastatic colorectal cancer, because they don't see this picture. We as clinicians perhaps can bring more light to them. Of course, we're not going to tell them how bad is it if they are diagnosed with colorectal cancer, but perhaps put more effort in implementing colorectal cancer screening.
Well, thank you very much, and I'm sure the audience will agree we've had a very fruitful discussion, and I hope it's created some rise in awareness regarding colorectal cancer. So to wrap up, just some take-home points in that we must understand that colorectal cancer incidence in Malaysia is rising, that it's multifactorial causes, and so there's no one magic bullet that you can hit to prevent it. It is still most prevalent in the middle age and the elderly, but we're starting to see really a rising incidence in earlier age groups, and unfortunately they don't fall within the screening population. You can reduce your risk a little bit with lifestyle changes, but as Prof. Khong said, all of us have got somewhere between a 6 to 7% lifetime risk of developing it. But light at the end of the tunnel is that in the early stages it's curable, but this is where screening is essential, because you can have a polyp or colorectal cancer for even as long as 10 years without having symptoms. So screening is essential, and if we can detect them earlier, we can get better treatment outcomes. And after that, unfortunately, it's not the end of the story, because we will still have to keep an eye on you, which is called surveillance. But again, if we watch you closely, we can pick up recurrences early, and hopefully that will lead to better outcomes. And finally, for our medical students here, it's not just about the technical, it's not just about doing the scopes and getting the biopsies and doing the operations. We have to treat our patients holistically, so that not only do they survive better, but they have a better quality of life. So with that, join me in thanking our panel for their fruitful discussion, and I hope you have a pleasant rest of the day.